Hello everyone. So this is a video of doing SICS in my way. So this is the type of method of SICS I do nowadays in my prior practice. So I started my fellowship with doing SICS by taking superior actors forceps. And one day, one of my senior consultant, Dr. Sekhar Sangit sir, told me that would you like to do SICS till rest of your life, or you want to do clear corneal topical phaco? So my answer was clear corneal topical phaco. So sir told me that if you want to do clear corneal topical phaco, then why are you taking superior actors? Use your left hand as much as possible. Then and only then you will gain confidence. So in this case, I'm doing that thing, the technique which I've learned in my fellowship. So after doing conjunctival peritomy, I hold the tenons with my Hoskin forceps, and then I take my 2.8 keratom and made a little groove in the superior in just sclerocorneal area with the 2.8 and hold it with the Hoskin forceps to make it fix. Now I don't use crescent knife to make the tunnel, sclerocorneal tunnel. I take uh, 2.8 keratom because what I've learned in my fellowship, which was taught by one of my consultant, Dr. Girish Budhrani sir, is uh, that crescent knife is used for laminar dissection. So crescent knife causes laminar dissection. So if your incision is direction is little superficial or little deep, the crescent knife will go on that area. But if you use blade like 2.8 keratom or any other blade sharp instrument, you if you are seeing that your direction getting superficial or deep, you can change your direction to the normal side, so that you will have a great good sclerocorneal tunnel without making any further complication. Now as you can see, there's a lot of blood is coming out because I never do cauterization of the conjunctiva, because what I believe that when you cauterize the scleral vessels, then what will happen, it will cause more deepening of the sclera, and it may causes more astigmatism. So I never do cauterization. And also the blood which is we are just seeing, it get heal after a few days. No, sorry, the blood which you see, it get healed when you close the case. So now I'm making the side port, and then I stain the capsule with trypan blue, putting little air in the endothelium because it will help to stop staining the endothelium. Now after around 10 seconds, I clean the anterior capsule and washed the anterior capsule with BSS, and the entire anterior capsule has been stained. Now after forming the anterior chamber with visco again, now I'll perform the rexis. So uh, the reasons for staining this mature cataract uh, with anterior capsule is, yeah, it's separate. It makes a difference between anterior capsule and the nucleus, so the rexis becomes a little easy. Also in my fellowship, I have learned by Dr. One of my again one of my senior consultant, Dr. Teja sir, told me is that the anterior capsule reduces the elasticity when you stain it with trypan blue. In this type of cases, the elasticity is reduced, and uh, so that you can able to do rexis properly. So there is no chances of rexis run out, and you get firm grip and control. And and most and all of my phaco case, I stain my entry capsule with Saint entry capsule with trypan blue. But in SICS, if lower grade cataract is there, I never stain it because already lower grade cataract have good elasticity. But in phaco I does it. I do it. So after doing rexis, the rexis around 6 rexis. So because it's SICS, so I have to remove entire the nucleus in toto. So I did a 6 mm axis, and also I will going to put PMA lens, so there's no issue. 5 or 5.5 mm axis sometimes become little tough, little complicated, because if you do this type of smaller axis, there's a chances of tear in the posterior capsule, and if you do it, and unfortunately, then you have to use SINSKI hook to dial the nucleus to the intercapsule. But since 6 mm axis is there, so after doing hydro, the half of the nucleus just came out, and with the hydro cannula I'm removing the entire nucleus. And while dialing the entire nucleus to the antechamber, I'm repeatedly doing the hydro and removing it, but and dialing it, and just remove in the antechamber. Now again filling the antechamber with visco. Uh, I take the uh, wire rectus, and with the counter traction force from the opposite side of the conjunctiva, I remove the nucleus, and now the only cortex is remain. So I have to use my synco cannula, which has dual irrigation and aspiration part. So with the help of synco cannula, I remove the remaining cortex. So since it was mature cataract, so not so much cortex was there, but I'm still cleaning some of the filaments and polishing the posterior capsule. Now the reason of polishing is that the posterior capsule, so that epithelial cell migration becomes less and causes less chance of PCO. And also, since the axis is circular, so chance of PCO is also less. But somehow, some for when you do SICS and put PML lens, the chances the after 4 years or 3 to 4 years or 5 years, if you're lucky enough, the PCO will be there. Because what we happens that when we put PMA lens, when the wound get constrict, when the anticapsule will get constrict, the posterior capsule will get constrict, then it will push the PMA lens little anteriorly. So the gap between posterior capsule and the PMA lens becomes, the optic part becomes more, and after 3 years or 4 years or 5 years sometimes, or sometimes it causes chances of PCO. Now the forming the anterior chamber with visco. Now I put my PMA lens. So it is a yellow PMA lens, so that patient is old patient. So putting yellow PMA lens, patient won't have any diffraction, and uh, the sensitivity of light is very less. I never do use clear PMA lens. I always use yellow PMA lens in my patient. So putting the leading haptic in the bag, with the help of dialer, I put the entire the lens in the bag. Now by dialing it, remaining few cortex just came out in the antechamber, and with the help of Simcoe, I removed that cortex also, and also I was tapping the PMA lens, because the visco which is behind that PMA lens, the optic part, when you tap, the visco comes out, and you can easily aspirate the remaining visco. So the entire case has been finished. Now sealing the tunnel, and closing the case. Now one thing I have to say, that in my fellowship, one of my senior consultant, Dr. Nisa Huja ma'am, my mentor, she told me that when you go to your state, please teach your juniors, because when you teach them, then you will learn more from them. So that's why I'm offering fellowship course in Gwalpara district to all my juniors who wants to learn cataract surgery. Interested one, please call me, please text me, please message me, and thank you. And Have a nice day and hope to see you soon. So last few closing, I never also never do cautery, just conjunctiva closing is there because it heals easily. Yeah, thank you.